Hello, my name is Gwendolyn Kukel. Thank you for joining me today as I present my program analysis and intervention plan that's focused on the maternal health disparities among Black women in the United States. This presentation builds on my earlier community analysis and will specifically examine gaps in services that contribute to these disparities, as well as propose an intervention plan designed to address them. In the slides that follow, I will describe the community problem more in detail and outline a new intervention plan called the Black Maternal Health Equity Initiative and walk through its goals, objectives, key components, and expected outcomes. My hope is to show that not only the challenges, but also the strengths and opportunities are there for change, emphasizing how social work values can guide solutions rooted in equity and empowerment. So the community problem centers again on the maternal health disparities among Black women. And despite advances in medicine, Black women are significantly more likely to experience pregnancy-related complications and even death. The NIH reports that between 2018 and 2022, Black women had one of the highest maternal mortality rates, reporting 76.9 deaths per 100,000 live births, second only to American Indian and Alaska Native women. These disparities are not explained by income or education alone. Instead, they reflect systemic racism, provider bias, and policy gaps. Service gaps exist in areas such as culturally responsive healthcare, insurance coverage, and preventive supports like doulas, and a lack of provider accountability. So the intervention, which again I am calling the Black Maternal Health Equity Initiative, or BMHEI, will bridge service gaps by combining several strategies: provider training to reduce bias, patient advocacy to ensure women's voices are centered, and technology to improve monitoring and communication. So the first circle we're going to look at is provider training, which focuses on reducing bias, building cultural humility, and improving accountability among healthcare providers. And this is critical because research shows that implicit biases directly impacts whether Black women are believed, how quickly they receive care, and ultimately their health outcomes. And training ensures that providers are not only aware of these biases, but are well equipped with the skills to address them in practice. The second circle is patient advocacy, which centers Black women's voices and empowers them in decision-making throughout the maternal health process. Advocacy tools such as community health navigators or the doulas that I previously mentioned amplify lived experience and make sure women are not silenced in medical spaces. This builds trust and strengthens relationships between the providers and patients. The third circle is technology, which supports the initiative by monitoring outcomes, providing secure communication platforms, and driving data-based improvements in maternal care. Using HIPAA-compliant systems ensures both privacy and accountability, while also giving patients and providers real-time tools to track progress. Where these three strategies overlap, we see the core values of prevention, empowerment, and accountability. For example, provider training plus advocacy builds trust, while advocacy plus technology strengthens women's voices through secure communication. And technology plus training improves provider accountability with reliable data monitoring. So again, we see at the very center of the model, the BMHEI itself, which is a comprehensive approach that bridges these service gaps by combining direct services with systemic change. This is how we move forward toward equitable maternal health outcomes for Black women by addressing provider-level biases, centering patient voices, and building in systems of accountability, support, and technology. The goals of the BMHEI are twofold. First, to reduce the disparities in maternal mortality through provider training and accountability, and second, to expand access to culturally responsive care models, such as the doulas and the midwives. Technology will support both goals by providing secure platforms to track outcomes, share data, and communicate across agencies while ensuring ethical safeguards like privacy and informed consent. This slide highlights the three main objectives of the Black maternal health equity initiatives, each connected to the use of technology. The first objective is to use HIPAA-compliant case management software, such as CareLogic or Apricot, to securely track outcomes and support communication. This is important because it allows providers and social workers and other advocates to share data in real time, improve coordination, and it measures progress while keeping patient information safe. The second objective is to develop and implement an ethics protocol for technology use, including privacy safeguards, informed consent, and culturally responsive communication guidelines. This is critical too because technology can either build or break trust. Without clear ethical standards, communities that have historically faced exploitation and neglect may feel unsafe engaging with the intervention. The third objective is to establish a monitoring and evaluation system that reviews the intervention's use of technology on a quarterly basis. This ongoing review process is important because it ensures accountability, helps identify issues early, and allows for adjustments that keep the program responsive to the needs of Black women. So together, these objectives ensure that technology isn't just a tool for efficiency, but a mechanism for equity, trust building, and sustainable systemic change. The target population for this intervention is, of course, the Black women, but mostly the childbearing age, generally between 18 and 45, who are disproportionately affected by systemic barriers in healthcare. This group faces unique challenges due to racism, economic inequality, and policy neglect, which contribute to poorer maternal health outcomes. Particular attention should be given to Black women living in maternal care deserts, which is a term I had not heard of before, but these are areas where there are no hospitals offering obstetric services and very few OBGYNs or midwives, or have long travel distances to access prenatal or delivery care. According to the March of Dimes, in 2022, more than 2.2 million women of childbearing age live in these maternal health deserts, and Black women are overrepresented in this population. Living in such areas compounds the barriers created by wage inequality and lack of insurance coverage, making access to culturally responsive and timely care even more difficult. Families and community organizations are also key stakeholders in this intervention. Improving maternal health outcomes for Black women has a ripple effect. Strengthening children's health, family stability, and communities' well-being is the target. And by targeting this population, the intervention directly addresses one of the most pressing inequalities in the U.S. healthcare system. This slide highlights the main components that make up the BMHEI intervention. First, provider cultural humility and anti-bias training ensures that doctors, nurses, and midwives are better prepared to serve Black women equitably. Insurance advocacy for doulas and midwives services addresses cost barriers and pushes for expanded coverage of evidence-based supports. Community health navigators help women access care, connect to resources, and overcome systemic barriers. Case management and secure communication platforms improve coordination and give women a safe, private way to communicate with providers. Finally, policy advocacy partnerships bring systemic change, making sure that lessons from this program inform broader reforms in maternal health care. Together, these components create a multi-level approach, supporting individual women while also driving structural change. So this program requires a multidisciplinary team, including a director, trainers, case managers, community health navigators, and IT support for technology implementation. Funding will come from a combination of grants, state funds, and private foundations. Training materials and case management software will be essential, as will partnerships with hospitals, clinics, and advocacy groups to create an integrated network of support. And this is what supervision and timeline will look like for BMHEI. Supervision will be provided through regular consultation with licensed social worker and healthcare professionals, ensuring that professional judgment is guided by social work ethics. A technology oversight committee will review data and privacy compliance. Um, the first 3 months will focus on preparation, the next three on training and ethics implementation, and the remainder of the year on direct service delivery, monitoring, and policy advocacy. Expected outcomes? Well, the expected outcomes include a measurable reduction in maternal mortality and morbidity rates among Black women, improving access to culturally responsive care, and greater provider accountability. Outcomes will be measured using data from the case management system, patient surveys, state and national maternal mortality tracking systems, and reports on policy advocacy progress. As I close this presentation, I want to thank you for your time and attention. Addressing maternal health disparities for Black women requires both awareness and action, and I hope this intervention plan has shown how social work can play a meaningful role in advancing equity. This is a problem that's near and dear to my heart, and I thank you for your time.